Welcome to this webinar, which we have set up with GM Cancer to, educate and inform about the genomic testing pathway in prostate cancer. Things have changed recently in the way that we're able to test for genomic variants and mutations in prostate cancer, and we'll be rolling out across GM Cancer a program to do this. And this webinar really is to provide you with the information and resources really to do this for your patients. First slide, please. So we've got a program today with 3 clinicians who are involved with the genomic testing to take you through this pathway. And we're going to give you some information about genomic testing in general in prostate cancer, I suppose the indications for doing this, for consenting patients, and I suppose what happens depending on the patient's results. My name is Andrew Hudson. I'm a clinical oncologist at the Christie. I work in prostate cancer. And today we're joined by my colleagues, Hayley Coleman, who is an advanced nurse practitioner at the Christie, working in genomics, and also Sarah Pugh, who is a consultant genetic counsellor. And we're all going to give you our perspective on different parts of the pathway. Next slide, please. So the first section is genetic testing in prostate cancer, and this part of the talk really is about identifying the correct patients to test and how to go about initiating the testing pathway. Next slide, please. So as I said at the start, things have changed recently. In NHS England, the ability to test prostate cancer patients for genetic alterations has come about, and it's a very important part of the management of prostate cancer patients so that we can advise them about their familial risk, and this also helps them speak to their family and allow their family the opportunity to be tested if required. It's important that we identify these patients because we know that patients with these alterations and variants can have a significantly increased risk of developing cancers, and not only prostate cancer, but also cancers like breast cancer and ovarian cancer. And it's important that we identify the patients if they have a familial risk so that the other family members can be informed and then referred appropriately for testing. And there is a specialist, service to do this, at St Mary's with qualified geneticists and genetic counsellors, and it's important that we, allow our patients and their families to access that service appropriately. Next slide, please. So the way of doing this is what is described as mainstream testing. So the reason for mainstream testing is really that this is a test that should be done in a large number of patients, and the clinical resources within NHS to do this need to be spread out to the clinical teams that are seeing these patients, to allow us to efficiently identify those patients that need testing rather than just everybody going to clinical genetics, because there are many patients who wouldn't need any testing, and there are, actions we can take early on in this process so that we can identify the patients who don't need to be referred, to free up the clinical genetics service for patients who do need to be seen and do need to be kind of investigated further. So mainstreaming basically means that we are, taking this test that was, traditionally done by the genetics team and genetic counsellors and trying to do a portion of this ourselves to see if we can identify the right patients to be seen by clinical genetics. And this has advantages for our network and for our patients, because it means that we can streamline the process and we can get the patients that need to see the clinical genetics team, I suppose, efficiently and more quickly if the genetics team are not having to see lots of patients who don't need to be seen. This is, I suppose, this kind of service is provided with the backup that we're going to provide some guidelines of how to identify patients and how to refer them. But I suppose the core element of this is that if you are unsure about whether or not your patient is suitable for testing, or there is something out of the ordinary that can't be answered using the algorithm or the test, that you still obtain clinical genetic advice as you usually would. So I'm going to now discuss with you about I suppose, some of the tools that we have to facilitate this process of identifying the correct patients to be tested and to refer. So I'm going to be talking to you about the algorithm that we have, a scoring system that we use to determine the familial risk, and then I suppose our documents will also be reviewed in terms of the consenting booklet and the frequently asked questions document. Next slide, please. So first of all, we'll start with the eligible patients. So not all patients with prostate cancer will be eligible for testing. So we're testing these patients to see whether or not they carry a gene that might increase the risk of a familial cancer. I suppose, unfortunately, cancer is extremely common, and prostate cancer is extremely common. And whilst we may have patients who do have relatives with prostate cancer, not all of those patients will be eligible for testing. And that's because it's a good thing, really, that the majority of patients will not have one of these genes that predisposes them or their family from developing cancer. So the criteria is quite strict to determine those patients who have a higher chance than the average of having a change. And I suppose for guidance, and the NHS has provided this criteria for us to assess patients. Now, as I said on the previous slide, this list is a guide, and it is a guide for us to be able to test patients prior to being seen by clinical genetics. But if you have a patient who doesn't fit this criteria, but you are suspicious that they may have a high risk of cancer, or you just want advice regarding this, there is the support to be able to do this. So if you were unsure, you wouldn't test the patient, but you would advise from our clinical genetics service, and we'll advise you how to do that. But the broad criteria for eligible patients are the three at the top, which are basically young patients with prostate cancer. And those are defined as patients under the age of 50 with any type of prostate cancer, so any localized prostate cancer, any diagnosis of prostate cancer at all in a patient under the age of 50 would mean that they are eligible to have their genomics checked for things like a BRCA2 variant. Other patients, metastatic patients, the criteria to be tested is slightly looser because these patients are less common and have more aggressive disease. So if the patient is under 60, they are also eligible to be tested. And then the final category for the top three are patients with Ashkenazi Jewish heritage and prostate cancer at any age, because we know that prostate cancer that is associated with genes such as BRCA2 are more common in the Ashkenazi Jewish family. So those are the three very easy to determine criteria based on, I suppose, demographics and seeing patients for the first time. And they should be used, I suppose, in a very rigid way to determine patients who should be tested. If a patient is 51 with prostate cancer, they do not fit the criteria to be tested. Now, there may be other, if they have localized prostate cancer, there may be other reasons why you might think that they are higher risk, and that can be discussed. But in terms of just your average patient who presents with prostate cancer, they have to fit these three criteria. The final criteria, so the fourth one, is based on the familial risk, and this is a little bit more difficult to calculate. It's not simply a case of looking at the date of birth or the patient's demographics. This is more about, I suppose, assessing the familial risk, which is a very complex thing to do, but we have got some, I suppose, resources to try and guide you with that. Next slide, please. So this is the pathway, and I'm going to talk about different parts of the pathway. We've kind of talked about the diagnosis. So we have a patient in front of us, who's been recently diagnosed. Do they fit those three criteria that I mentioned about the age and demographics? If they do, they are eligible for germline testing, and that's germline testing that can be done from your clinic. And I suppose we'll tell you how you can do that. If they don't fit that criteria, but they have a family history, then they will be assessed using the Manchester score, which we'll go into a bit more detail. But just assuming that your patient does fit that criteria, so going down, I suppose, the left-hand side of the screen, they have they're a young patient, or they have Ashkenazi Jewish heritage, that they would be tested in your clinic using a blood test. So we go down to the next bit, the urology clinic, and anybody that has been trained to do this and that has attended this webinar and has, I suppose, a defined role within their urology department is then able to take on this and test the patient. So I'll explain a little bit about how that is done. So it is a blood test. So germline testing is done to test the genetics of the patient rather than the patient's cancer. So a blood test will suffice. I'm not going to go into the somatic testing here, but that's a different type of testing. This is germline testing. So this is using the blood sample of the patient to look at the genes that they were born with and the genes that they may have passed on to their family. So it's done with a blood test, and it's a simple blood test that can be taken in clinic. It requires, like any blood test, a form, and it's a slightly different form to the one that you will use in your clinic for all your other blood tests. But this is available from the website and can be printed out. And I suppose we're going to give you some guidance about how to do that. The blood test will be sent off to the lab, and this will I suppose this is approximated to take between 6 to 12 weeks. This may change in the future. I would imagine that it will be quicker in the future, but I suppose the message here is that it will be sent off, and then you will get 3 different results. And I think, Sarah, you're going to be talking about the different results, so I won't go into that. Just straight into your territory there. Depending on the results, then there will be I suppose, an outcome, again, following this pathway, and I suppose we'll be talking to you about that. Can I have the next slide, please? This is the Manchester scoring system. So this is, I suppose, this is the most technical element of the whole kind of procedure for us to test in the mainstream, is to try and identify patients who do not fit those initial 3 criteria, but may have a family history that warrants further testing. It is it alright? Sorry, are you describing this? I don't want to stray into the area that you're talking about. Shall I carry on talking about this?
It's not in mine.
It's not yours. It's not in yours, is it, Hayley?
No.
I didn't want to tread on your toes with this. Okay, so I'll just do a brief description about this. So this is using the family history of the patients. So rather than the I suppose the demographics of the patient, so their age or their ancestry, this is more to do with their relatives, and it's a score to try and work out what the risk is of them having a genetic cause of their cancer, an inherited genetic cause of their cancer. And so it requires a knowledge of the family history. Now, this is something that obviously we can ask about as non-specialist clinicians. I think Sarah would agree, it's probably much better done in the genetics clinic. I suppose, finding out about people's family history can be quite complex. And, obviously, I think we're probably all aware that sometimes when we take a family history, there isn't sometimes a lot of detail. But this is a tool, I suppose, for us to try and identify those patients who have a barn door kind of higher risk of having one of these variants. So it requires asking about, I suppose, both sides of the family. It's important to note that scores for both sides of the family should not be added together. So the patient's mother side of the family shouldn't have their score added to the patient's father side of the family, because this isn't a test to look at, I suppose, the risk of the patient. It's a risk in their sides of the family, and obviously their mother's side of the family are completely separate kind of genetic line to their father's side of the family. So we mustn't add them together. We do one and then the other. And then when we've worked this out, and you can see there on the second page of this, there are different scores that you have for different types of cancer in the family and the different ages. And obviously, the younger that a patient's relative has a cancer, the higher risk that they may have a genomic change, and therefore, I suppose, the higher risk that patient may also have that type of change. So we're working out the score. This score doesn't tell us an absolute value, doesn't tell us whether or not a patient is going to have one of these changes. It doesn't tell us whether or not they should, whether or not we can get away with not testing them. I suppose it tells us what their genetic risk is, and if they reach a certain threshold, that means that they're eligible for testing. My experience of doing this is that some patients are slightly disappointed when they only hit 13 on the score and they need to have 14, and they feel slightly shortchanged that they're not able to have the test. But I think a way of looking at it is to say really that this is a good thing, because your family's genetic risk is not high enough that we think that you carry a gene that we need to identify. So this is a challenging part of the pathway. We're happy to give any guidance, and I think probably initially when you start doing it, you may need some guidance from us to if there is a particularly complicated family history. And I said again, as I said previously, this is one tool that helps us make a clinical decision. It doesn't completely guide the management of the patients. And if you test a patient and they do not meet the score, but you are still concerned, for whatever reason, or you need advice, then it is still possible to get advice from clinical genetics about these patients. I think that's all I've got to say on the scoring system. Next slide, please. Oh, that's a bit bigger. So basically that just takes you into, I suppose, the scoring system. There is a slight adjustment based on the actual patient. So I said that most of it's based on the family history. There is a small adjustment made for the patient, so that if a patient is younger, again, I suppose it is taking into account that patient as well and their risk. And if they're younger, they get a slightly higher. They get an extra point added to their score compared to a slightly older patient. Next slide, please. Thank you very much. So I'm now going to hand over to Hayley Coleman, who is an advanced nurse practitioner at the Christie, who works in prostate cancer. And one of her areas of expertise is to actually do this, the familial risk testing and the genomic testing. And over the last, I think probably about the last 9 months?
9 months, yeah.
Hayley's been, I suppose, doing this in practice in the clinic every week, and has built up an expertise, I suppose, on that part of the pathway. So I think she's probably best placed to describe what happens next.
Thank you. So, as Andy said, we've been working in collaboration with Greater Manchester Cancer Alliance, and we've created the Genomics Clinic. So that's been running for about 10 months now. So my involvement has heavily been within that clinic, as Andy said, supporting patients with information. And the purpose of this part of the presentation is so that you can see the kind of the criteria and the information that we need to provide to our patients, also the consent process, and then the scenarios that can come out. So some of the questions that patients will ask about the testing and why we're doing it. So as with anything, patients must be provided with information on the tests they've been offered, and they must consent to this being done. And we need to look at the areas we need to inform them, and that would be why we're doing the test in the first instance, what the test itself actually involves, how the results will be returned, and actually what the benefits of having the test are to the patient, and also what the downsides of having the test are. And we need to be looking against the criteria to see, does this test actually need to be undertaken in the first instance? So someone could be inappropriately referred across, so we need to kind of look to say we don't need to be testing that individual and explaining to the patient why. So we're doing the test because we know that some cancers can be caused by genetic alterations, which we can test for. Patients who meet the criteria, and that criteria can be found on the National Test Directorate, are eligible to be tested for the specific gene alteration. So if the gene alteration is found, we can place them on surveillance, or we can conduct sort of preventative treatment for any of the other cancers that they may be of an increased risk of. Additionally, if that patient is positive, then that means that first degree relatives are also eligible for testing. So again, this kind of, if they also test positive, they're in the same scenario, that they're at increased risk of cancer. So that makes them eligible to go on a surveillance programme, or to be offered preventative treatments dependent on the cancer. The test itself is a simple blood test, so we have to do that using an EDTA blood tube. So we have a referral form that we complete, and we send that across to Northwest Genomics Laboratory Hub, and that's at St Mary's Hospital. With regards to the results usually come back via the method you request on the form. So I usually put my email address and the secretary's address for that information to come across. But if you work in an area where you have online portals, as long as they're protected against data protection, etc., then you can ask for that your results to come through onto that. And I usually guide patients that results can take up to 6 to 12 weeks. I probably say around about the 12-week mark, so that they're not kind of chasing results or becoming anxious of the results sort of prematurely, really. The benefits of the test I've just touched upon, but if the patient has a cancer-causing gene alteration, it is possible that this has caused their cancer, and their relatives become eligible for testing to check if they are at an increased risk of developing cancers also. They would undergo surveillance testing if they also test positive for the gene alteration, so it helps the family kind of understand where their risks are. If the patient doesn't test positive for the gene alteration, then it may reassure them that their cancer is most likely not caused by an inherited condition. However, if the patient does have an extensive family history of cancers, then they can still be referred across to clinical genetics. However, that would just go as a routine, on a routine waiting list. It wouldn't be fast-tracked through that process. And then clinical genetics will take over from there to see whether they need to be, further tests need to be done. The negatives of the test are that obviously some patients are at the beginning of their cancer journey, so they may already have some anxieties with regards to the diagnosis. They may be struggling with that, and they may feel anxious about treatments, etc., or even anxieties of the potential result on their family members. So we have to really bear that in mind, that this is more kind of emotional side of the scenario when we talk about cancers. And if there's no gene alteration, then some patients can be a little disappointed by that, because they actually feel by having an alteration that if the family members have got it, then they're going to get almost an improved service from a surveillance point of view. So we have to reassure patients, as Andy said earlier, that actually it's reassuring that you haven't got it because you're at no extended risk than the rest of the population. So there shouldn't be any need to be doing these surveillance tests or sort of preventative treatments. So they may well be kind of over treatment that for those patients or people. And then we need to look at, does the test have to be done? So some people decide that having information regarding a possible genetic cause for their cancer is not helpful, as I said earlier, for an already difficult and emotional time for them. But if the patient decides at a later date they would like to have the test, then they should just get in touch with the medical team and they can be added back onto the pathway. If a patient decides that they do not want to be tested currently, and maybe not even in their lifetime, then we can talk to those patients about sending a blood sample off that we actually store. And then the family members can access that information at a later date. So should they wish to find out what their inherited risk is, or if their family member indeed had a gene alteration, then they can make those arrangements with clinical genetics. But when we fill the form in and send that across, we do send the blood test across, and we have to say quite clearly that the DNA is to be stored and not yet tested. Even if a patient has declined in the past and DNA has not been stored, well, they can still be offered testing in the future. However, if they're no longer going through mainstreaming pathway, and if they're no longer receiving ongoing care, then they can't. We have to refer them through clinical genetics for those patients. If they are still having ongoing care, then they can be tested via the mainstreaming pathway, as I've been doing in the clinics. Patients can become eligible at a later date, and that goes into a little bit of a more complex arena. But for our prostate patients, if they're progressing on therapies, then we can look at, and they have inadequate somatic testing, then we can germline those patients. And again, as long as they're still receiving ongoing care, we can do that through the mainstreaming pathway. Anything outside of that, that's referrals to clinical genetics directly, and they take over. And then if anybody is uncertain about patient eligibility, then the Manchester Centre for Genomics website is a really useful tool. So you can go in and you can see if you can work out between the guidelines whether you think that patient is suitable. But if you're still struggling, then you can always contact clinical genetics at St Mary's, and they will be able to help support you with that. So with regards to information, it's really important that this is a kind of a two-way street. So we need to understand what's important to the patients as well. So it's important to understand the patient's concerns and support them in making the right decision. And the decision doesn't just involve them, it does involve people around them, doesn't it? So it's to help guide with that, and it's to remind them that that we're there to support them throughout the testing process and after. So we need to sort of understand that, or be clear that they know who their cancer nurse specialist is, because they're a good point of contact to guide them through and support them. But I think what's important to do is to know what their concerns are and how they feel we could support them with that. And I think we need to be open and honest and transfer them out if they need additional support along the way. Do they have people at home? So we need to take into consideration, are any of these patients isolated? Are there any safeguarding issues that we need to kind of look into or address? So we don't need to delve too deeply, but I'm sure, as most clinicians will see, these things become quite apparent in the consultations if you just allow some key opening questions. And then to establish if they know who the cancer nurse specialist is. So quite often they'll say no, they've not got one, or they'll say yes, they have, but they've lost the details and they've not got them. So again, I think we should take a level of responsibility there of making sure they know actually who the cancer nurse is, and make sure that they have got the contact details should they need any support. And then just to let the patients know that they will be fast tracked. So if they are positive, we would fast track them to clinical genetics on receipt of us receiving those results. So they would be called in to have a chat, and then they would obtain consent to speak to other family members at that point. I think, we get some common themes really in questions that patients ask. And one of them is, if a test positive, does that mean my children will definitely get cancer? Well, the answer is no. This is not a diagnostic test. The children may well not even inherit the gene. And if they do inherit the gene, it doesn't mean that they're going to get cancer. They're just at a more elevated risk than the general population. So we need to make that clear to patients, really. Some may ask, if they don't have children, would it affect their ability to have children? I generally haven't been asked that question from a prostate point of view. However, the answer is no. It's not going to affect their ability to have treatment. But we do need to look a little bit beyond that. So I think we should, if patients are undergoing treatments for cancers, then we should direct them to the clinician so they can ask those questions in case those things are linked. Will it impact on anyone else in the family? Well, essentially it does, doesn't it? So if they're negative, then you could argue, no, it doesn't, but actually family members are usually involved. So there may be a level of anxiety between all of them about, the apprehension of what the result would mean to them. So we need to give reassurance in that regard, that it's a more proactive approach rather than reactive, and that there are, an advantage against the rest of the population, really. How do we talk? How would they talk to the children? And again, that can vary from each individual. So we need to establish what their dynamics are, how old the children are, do they have any extensive needs, do they have any estranged children that they might need to get in touch with in the future, or siblings, for example. So it's about us finding that information out. And in some cases, we just advise that maybe you don't need to let the family know until you've got your results through, but we can't make those decisions. We can only give certain spins on the scenario so that they can help them, help guide with that. We get asked questions about, will it affect the health insurance? Well, a positive gene alteration wouldn't affect health insurance. And then they will also ask, will it affect the children financially? So things like, would they be able to get mortgages, loans, etc. So again, no, if children test positive for gene alterations, then they shouldn't be penalised for that. So they should still be able to obtain mortgages and life insurance at the same premiums as other people. And then this is the consent form that's been created by Greater Manchester Cancer Alliance. So this will be sent out to all trusts so that you can use this as a framework. And it just goes through, I suppose you just need to make sure that you're on your consent registers, etc., if you're working in those clinics. But then it's making sure that you just cover these key points with the patient. And it's that they are agreeing to have germline testing. And in our case, it's BRCA2 for prostate, breast, and other variants that might be linked to that cancer, those cancer groups. Understand that this is not intended to diagnose any cancers. And to give them an opportunity. So to understand that we've given them an opportunity to discuss what the test means and what the results may mean to them. That the sample is stored, so we need to make that clear for patients. I think they do have an option if they don't want the DNA storing to have that taken away, but none of mine have asked me to do that as yet, but I'm sure there are patients that don't like the idea of that. And then just to say that we would possibly, that information is shared between clinical genetics and us with regards to results. And then, as with any consent form, the patient would sign, print and date, as would the clinician. And I provide the patient with a copy, and then I get a copy uploaded to the patient's notes, so it's clear that they have been consented to this procedure. And then this last slide is just a recap, really, to say that once we've gone through all the information, if patients are happy and they've been consented, then we just take them through. They have the blood test taken, and we send that across to the Genomics Laboratory Hub at Manchester. We have a referral form that we fill in that goes with the blood sample. So we just need to make sure that we're filling that in appropriately, that there's nothing missed off the form. So double check it, because you don't want to be calling patients back for repeat blood tests. And then we do need to use a clinical indication code, and that's very clear on the form where that needs to go. And for this specific, for the prostate, breast, BRCA, is the R430. But when you go on the listing, you can see all the other rare clinical indication codes that you might need to use along the way. But I would always urge that you get advice on that, really. And I think that might be all of my slides. So over to Sarah.
Thanks, Hayley. So the last slide there with Hayley talking about the clinical indication is a really good place for me to start, and that's because that is the indication within the genomic test directory for inherited prostate cancer. And currently there's a number of genes on the panel that's covered by R430. That may change over time. And so it's important to recognise that the test directory is updated regularly, including, I was looking as Andy and Hayley were talking about what the eligibility criteria was. And there's a really new an interesting one there, which is actually having a grandparent from Shetland as well. So that's something that maybe people might want to add into their family history taking, is now knowing if you have more than one grandparent from Wolsey, one of the islands in Shetland, and a prostate cancer at any age, you are now eligible for 430 as well. So keeping up to date with the test directory is really important. But today I'm going to talk a little bit about possible genetic test results. And I would say that the results of any genetic test, no matter whether they're about an inherited predisposition to cancer or not, would fall in one of three main categories here. And so when I'm talking to my patients, I'll always say that there are three possible outcomes. We might find nothing, we might find something, or we might find something that's a bit trickier to understand and explain. And I'm going to go through those in each in turn now. So the first one, if we don't find anything. Now, what that actually means is in the panel of genes that we've looked at, we haven't found any pathogenic or disease-causing genes. You've got about 22,000 genes in each and every cell in your body. Within the panel of genes for prostate cancer currently now, August 24, we're looking at 8 different genes. There's an awful lot of other genes there that may or may not have some kind of impact on your prostate cancer risk. What we're saying with a non-informative or nothing identified result from this test is that we haven't found anything in the high-risk genes that we have looked at to date. This would mean that there would be no any extra sort of action that needed to be taken, because that would reduce the likelihood that that cancer was caused by a genetic alteration in one of the currently known high-risk genes. Now, as Hayley was talking about, actually, while we may feel that that's a good news result because they haven't had a genetic alteration identified, still they may still be asking why it's happened. They may have that other family history of cancers, and that's why it's really helpful to know more about who's who, what's what in the greater family history. Second possibility is that we find something. Now, this could be described as either pathogenic or likely pathogenic. So pathogenic meaning disease causing, or likely pathogenic meaning that there is a high likelihood that actually this is responsible for causing the disease in question, so a prostate cancer risk, but there's insufficient information to call it definite or a pathogenic. These are the families or the individuals where if Hayley found a pathogenic gene change in any of those prostate cancer genes in one of her patients, she'd be referring him into genetics to the mainstream clinic, where we see patients within hopefully 12 weeks, which might not sound very quick, but it's very quick in terms of some of our waiting lists. And we do try and see people quickly to be able to explain the genetic information. So in that clinic, if they have questions about their clinical care, we redirect straight back to the specialists who are involved with those, and we just talk about the genetics, and that could be family members, what predictive testing could be possible, who needs what in whether there's surveillance or screening options. If they have been found to carry a genetic alteration, then obviously Andy and Hayley will be talking, and all of you will be talking about what this might mean for their treatment. So those are two sort of separate areas that they might be getting involved with in terms of finding out about this information and learning more. It's very common for individuals to have lots of different emotions about genetic test results. Some of that can be guilt, and it's talked a little bit about here about guilt, having passed something on or potentially passing something on to your children. But also it can cause anxiety, it can cause a lot of stressful feelings around why this might have happened to them, but it also might explain a family history of cancer. It might explain why they had an inevitable feeling about a diagnosis in themselves. So actually, dependent on their family history, this could bring up quite a lot of information. And as genetic counsellors, we're very involved in support and a kind of helpful adaptation in terms of genetic test results. So the third possible result that you could get from one of these genetic test results is a variant of uncertain significance. So this would be a variant where we may not have seen it enough times before, it's not been reported enough, or it may be that actually it doesn't look like it impacts the gene and the function or the reading of a gene in a way that could be disease causing. So very often, if we think about genes as instructions or instruction manuals, when we're doing a genetic test, what we're doing is comparing an individual's germline, so the genes that they were born with a reference sample. Now, a variant of unknown significance could be as simple as a difference within the spelling of that gene. Sometimes an analogy I use in clinic is a little bit like an American spelling. So you can still recognize the word, you still know what it might be, but actually genes are 3D, proteins are 3D shapes. Actually, it might not quite make sense in a fully functioning way. It could disrupt the way a gene works, but it might not. And there's not enough evidence. So if I was explaining this to a patient, I would say, we found something, we don't fully understand what this means. And that is genuinely how we would explain those. It may be that we can review this information in the future. So using your usual follow-up plans within your clinic, within your hospital, a VUS might be one of the triggers that you want reviewing through the laboratory, and that might come up through your usual review system after about 5 years, that you might want to be checking in with that patient. If they had a VUS, you might want to get back in touch with the laboratory or the clinical services in terms of a variant review. There is an R code, as Hayley was talking about, in the test directory. We can look for an update for the variant interpretation using a different R code, and we'll be looking at the pathways in terms of how we can best understand that. I would say that these variants of unknown significance can cause more confusion and more anxiety for patients, because we're saying we may have found something, we don't know what we can do with it. And with a VUS, you cannot offer a predictive genetic test to a first degree family member. So this is something that could be identified in somebody who's had that prostate cancer diagnosis. So we could be saying, well, we found something in one of the genes that causes a risk of prostate cancer, but actually I can't use that for anything else. I can't test your family members to see whether they have the same gene change or not, because it might be over time that actually if this was reviewed, it would be entirely benign. So it wouldn't be a disease-causing change within that gene. And sometimes that can be one of the ways that we can explain things, but also it can be helpful to know that all of our genes have many changes in them, and that actually causes the differences between all of us and how we work and how we function and how we look. And it could be that actually our genetic testing has picked up something different to the reference samples that we use. Sometimes it's very important to think about ethnicity of your patient at this point, because a lot of the genomic and genetic reference information is on Northern European populations. So it may be that actually if your patient is from a different area around the world, they might be identified as having a VUS, which could over time be reassessed. So that's just an important thing to think about. And when you're thinking about referring into clinical genetics, our contact details are there. So we are based in St Mary's Hospital in Manchester, and it's very helpful to have any information about that you would usually put on a referral about a patient anyway, in terms of their demographics. But if you have taken a family history, if you've used a Manchester score, any of those pieces of information would be really helpful. If when you're doing that family history, someone says, oh, I think my cousin, my aunt, my daughter, somebody was seen in genetics, if you're able to put in that information, it would be really helpful, because we can try and tee up the files here. And it is always helpful to know in advance if we need to have an interpreter, just so that we can make our sessions a little bit more accessible and useful for our patients. And the next slide is our contact details for both the genetics service clinically and the laboratory. And the email addresses are checked regularly, and they're from the clinical point of view. We wouldn't really answer triage questions in that way. So if you were thinking about specific clinical questions about a triage, it might be worth giving the department a call and trying to ask to speak to one of the genetic counsellors or one of the cancer team. They'll be able to give you best advice, just because actually if you email into that, it may not go to the right person. But that was my last slide.
Thank you, Sarah. Thank you, Haley, as well for your talk. So I think that concludes our webinar. There was one thing that I suppose, just following on from those last couple of slides, in terms of the results. Presently, there is an email with the results. You get the results kind of via an email. An email address is put on the form, and you get the result that way. It's also sent in the post to secretary. But there will be and we're hoping that in the future there will be an IT solution, and that I suppose results will be obtainable kind of, but yeah, by an electronic solution. So that's really just to finish that bit off. So as I said, thank you for everyone for contributing, and to the Greater Manchester Cancer Academy for putting this together. And I think we hope that this has been useful in I suppose informing you and educating you about this process. And I'd be happy to be contacted if you had any further questions or any further advice is required regarding this pathway. Thank you very much.